Sir, just a minute. We are going to give us a minute. So we are starting with the webinar. We are live.
Yes.
Good afternoon, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our eminent stalwart who is present here with us today at our forum. Well, he's none other than the very renowned internal medicine specialist, Dr. Bansi Sabru, sir. Sir is MBBS, MD in internal medicine, DNB, FACE, FRCP, PhD, President and RSDTI Chief Diabetologist and Chairman of Diabetes Care and Hormone Clinic, Dia Care, Ahmedabad. Sir is also the Chair-elect of IDF Southeast Asia. With Sir's wonderful insights and with his incredible knowledge, we are going to talk about the session for today, which is insulin pump therapy and CGM interpretation. So before moving on to today's session, let us have a brief look on what the topic says. Well, paired with continuous glucose monitoring, insulin pump therapy represents a cutting-edge approach to diabetes management. CGM interpretation allows for real-time tracking of glucose level, aiding in precise insulin dosing and lifestyle adjustment to optimize blood sugar control. We'll be learning more about these technologies, offering individuals with diabetes greater flexibility and improved glycemic management with Sir's wonderful insights and with his incredible experience that he's about to share with us. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you.
First of all, thanks IGCP for this wonderful opportunity. Thank you for all the participants who joined for this afternoon webinar. What I'm going to talk on a continuous glucose monitoring and insulin pump therapy, a less talk topic in a routine webinar or a routine continuous medical education program, which is related to diabetes. But it's very, very important. And why it is important that I will be talking in next 25 or 30 minutes. I don't have any financial disclosure for this particular talk, but I'm on an advisory board member for many diabetes care pharma, and I have done clinical research of most of the present and many future molecules which I am doing. I am clinician since last 1997. I am practicing diabetologist at Ahmedabad, western part of India, at Nehru Nagar. We know that to deal with the diabetes, it was the DCCT and UKPDS trial which talk that a chronic hyperglycemia is responsible for a diabetes complication. And that's how we started controlling sugar and achieving a target A1C. But the biggest limiting factor for achieving a tight glycemic control was hypoglycemia. They were not able to get a good control of diabetes. Then over a period of time, we understood it is not just hypoglycemia or a chronic hyperglycemia, which is responsible for many of the complications. Even you achieve a A1C of A7 or even less than that, still the glycemic variability, which is again a very important parameter for a person with diabetes to have complication in his future. And that's the reason we have not only to control a good glucose control, no hypoglycemia, but at the same time, a person's sugar variation should also be controlled, and there should not be very variation in diabetes management. Over a period of time, we all started using continuous glucose, this A1C sugar monitoring with the glucose meter in last 50 years. But last 15, 20 years, a time had changed that from random blood glucose monitoring, we have moved to a continuous glucose monitoring. A continuous glucose monitoring have a receiver and a transmitter, and there is a sensor through which you can see continuously your glucose value also. Why continuous glucose monitoring is important? Because it minimizes extreme blood glucose variation. It gives you immediate feedbacks, and it also knows the direction where you are going for the sugar. The long-term benefit it gives you the patterns. It gives you the how you have to control your basals and carb counting and correction factor you can give. It also gives you the information that how you can avoid the low hypoglycemia and even persons with hypo unawareness. It gives you peace of mind with the fear of lows with the person who is having diabetes. So before 40 years, it is a necessity established the importance of A1C, but there are limitations with A1C because it does not give you the long-term there is a hypoglycemia and hyperglycemia in between. It just gives you the average of last 3 months. A1C reflects of last 2 to 3 months, but it does not address any glycemic variability. Even patient with the same A1C, they may have different glycemic variability, and they may have multiple times high or low glucose also. Like I gave you an example, in this patient who is having 100% time in range and the sugar is remaining between 70 to 180. The other patient may be on the extreme side. Actually, his sugar is remaining only 40% of the time in range, 40% of the time it is out of the range, and even it is going 20% of the time less than 70 also. That could be a severe hypoglycemia too. There may be a patient who may be on 70% of the time it may be normal, but 5% of the time may be going low, and 25% of the time it may be going up. So you may have a A1C of 3 different patients may be the same, but their glucose variability or their pattern of glycemic variability throughout the day may be different also. So trends are definitely better than points. If you are doing glucose monitoring through a glucose meter, you will find random blood glucose at that point of time, while the trend is going to show you a monitoring continuously that how it is showing the sugar up and down. There is a baseline. With the ambulatory glucose profile, it had become much easier because it gives you a 14 days of graphical picture. It gives you in 3 months how the sugar was. In 14 days, it will compress all the report in such a way that it will give you a complete graph. And it will also give you the median of it. That, in 50% of the time, the person's sugar is remaining like this. And then it will also give you the variation of even 10% time or 25% of the time when the sugar is going hypo and hyperglycemia too. There was a international consensus. I was part of this consensus that when the continuous glucose monitoring should be done. And this is after 2 years, we had come out with a time in range with the consensus of continuous glucose monitoring for all type 1 diabetic patients, those who are on insulin therapy and those who are having risk of hypoglycemia, those who are having risk of cardiovascular disease and frail patient, elderly patient, they all should be on continuous glucose monitoring if they are given a medicine which can lead to hypoglycemia. And then a consensus had come that how much time one should remain in the range. That is what we call is time in range. Instead of now a new parameter, instead of using HbA1c, we use a parameter called time in range. 70% of the time, more than 70% of the time, the sugar should remain between 70 to 180. Even somebody who's elderly, frail, hypo unaware, is still more than 50% of the time their sugar should remain between 70 to 180. If someone is pregnant, this time in range, instead of 70 to 180, the tight range, it becomes 63 to 140. So they should remain in a more tighter glucose control, again, more than 70% of the time if they are type 1. If it is type 2 or a GDM, then it is 90% of the time their sugar should remain between 63 to 140 if they are pregnant. The continuous glucose monitoring actually fills the information gap, which gives you the complete view. SMBG gives you the random blood glucose at that point of time. HbA1c gives you last 3 months average, but it's a continuous glucose monitoring, which will give you that continuously in 24 hours, how the sugar is going up or low. So actually these 3 core glucose technology are complementary and essential. And why I'm putting this slide, particularly for Indian patients, because our patients cannot afford continuous glucose monitoring, and they are using intermittently continuous glucose monitoring. So when we put all three together, a person who's doing finger stick testing, getting A1C also 3 months, and every 3 months or 6 monthly getting their continuous glucose monitoring will reduce the risk of hypoglycemia, will have a better control of diabetes, and at the same time, a glucose variability will be also significantly reduced. American Association of Clinical Endocrinology, first time, even after 2019, when the time in range concept has been established by all over the world, in 2020, American Association of Clinical Endocrinology first time put the continuous glucose monitoring, even it should be used for a comprehensive management of type 2 diabetes. If you see all the 11 principle, they had put 11 principle as in using continuous glucose monitoring whenever indicated to assist patient in reaching glycemic goals safely. We had also written a paper that time in range is a target for even type 2 diabetes, which is urgent need for that. Let me give an example that how a CGM can be helpful for type 2 diabetes. We all know that type 1 will be very much helpful because they will reduce the significantly hypoglycemia for better control and less glycemic variability. This patient who was on a triple drug therapy, patient with HbA1c of 9.5, and I'm sure any diabetologist, endocrinologist, physician would like to write him only insulin because sugar was high and 9.5 with a triple drug oral anti-diabetic agent, glimepiride, gliptin, and metformin. Patient was not ready. We had put on a CGM. We had seen the first 5 days, all reports for sugar were high. We explained that yes, the other injectable therapy can be given. This is GLP-1 as per latest guideline. Also, they talk before starting basal insulin, put the patient on GLP-1, which put the patient GLP-1, gliptin removed and added SGLT2 and reduced the dose of glimepiride 2. And alternate day, we were trying to reduce the glimepiride because we were worried of hypoglycemia. And when patient came on 10th day, you'll be surprised that patient sugar was absolutely well controlled and no glimepiride, no hypoglycemia 2. And last 4 days, patient is on GLP-1, patient on SGLT2, and patient is only on metformin. So how a guideline is talking about using insulin while when you are treating these patients on a continuous glucose monitoring, explaining the patient that how your sugar is coming, we are precisely treating and very much individualized treatment we could do it. And for this patient who was on a triple drug and we were supposed to give him an insulin, rather now we had come to patient on GLP-1, SGLT2 and metformin, and sugar is very well controlled with 1 tablet of SGLT2 and metformin combination and 1 injection of now, which is once in a week, dulaglutide. We started with once in a day, once in a week. So patient is literally on 1 tablet per day and sugar is still remaining so well controlled. Let me talk about the second part of the talk, that is insulin pump therapy. It is not new. Actually, in 1980, the insulin pump started to enter the market. In India, it was 502, which became most popular and which had come to India in 2001. We started using also since last 2022 years, and 2003 Minimade 512, which became very, very famous insulin pump, which also used to monitor the glucose level, and it was also available to our country. The treating type 1 diabetes, our primary aim is to normalize the glycemia. The way a non-diabetic person having a high sugar, at the same time insulin goes up. Similarly, when it goes down, the insulin also has to go down. And that's what in a normal person, a similar type of thing, we want it for a type 1 diabetic who is 100% insulin deficient. And we know that there are only 2 choices. Either you inject or you give by insulin pump, because that's a giving the insulin. This is one way by which you can give the insulin pump therapy. Now, continuous glucose monitoring is fantastic because it reduces hypoglycemia, it decreases glycemic variability. Definitely, it improves the glycemic control also. But in UK, recently, NHS now had put that all type 1 diabetic patients should be on continuous glucose monitoring. Still, only 30% of the patients are achieving tight glycemic control. It means they need something more for a better control of diabetes, and CGM alone is not enough. And that's how the insulin pump the complete journey of insulin pump, which started with Minimade, and now in India we have advanced hybrid closed loop system also. In a type 1 diabetic patients, definitely by putting the patient on insulin pump, it lowers A1C, it lowers diabetic ketoacidosis, and it lowers severe hypoglycemia. It have a better control of diabetes with putting a patient on continuous subcutaneous insulin infusion pump in compared to the patients who are on insulin therapy. It also gives you a better, less risk of hypoglycemia, even significant decreased risk of severe hypoglycemia also. Even with the pump therapy, there is a decreased mortality with the severe hypoglycemia in persons with type 1 diabetes. And just to give you an example, that in 1983, when patients were on multiple daily insulin injection, these type 1 diabetic patients on a DCCT trial with a mean A1C of 9, when they were put in for a tighter glycemic control, they could achieve 7.2. That was the median A1C, but the risk of getting hypoglycemia was 62 per 100 patient year. When the same patients were put on a continuous glucose monitoring, after 25 years, similar type of patient were put on a CGM, and you can see the risk of hypoglycemia decreased from 62 to 20. And the mean A1C also from 7.6, better tighter glycemic control to much tighter, which is 7.1. In a pivotal trial, which was a 670G insulin pump, which is a sensor augmented pump they had used, and you can see here the risk of hypoglycemia became 0. And A1C was, median A1C, they could achieve 6.9. So that's a tight glycemic control they could achieve without getting hypoglycemia because of insulin pump therapy. Why we need insulin pump therapy? Why can't we just put the patient on a multiple daily insulin injection with continuous glucose monitoring? A same patient on a CGM, you can find other day he could be in hypoglycemia, one day he could be in hyperglycemia. There is a possibility of dawn phenomena. Other day there could be possibility of Somogyi effect also. So the same person with a similar type of lifestyle, same therapy, same insulin, still there could be a glycemic variability. And for that, we need something which is just not a different basal insulin rate, which we set in a routine pump therapy. We need a pump therapy which have itself built with a artificial intelligence. As the sugar increases or as the sugar decreases, there is an insulin dose given by the pump has to decrease. When it increases, there has to be increase in autobasal. So this autobasal increase and decrease is important. And at the same time, the correction dose is also very important. As the sugar is high, there should be an auto correction. And this pump is with AI-based advanced hybrid closed loop system, which is available to our country. If the patient is on a multiple daily insulin injection with a blood glucose monitoring, actually they are achieving time in range around 45%. But those who are with MDI and CGM, they can achieve around 51%. With pump, the older pump and CGM, which are separated, we will achieve around 55%, and sensor augmented pump therapy will give you the 63% of the time they will be in range. But if you put them on a hybrid closed loop system, this was an older 670 or 770Z, they will achieve more than 70%. And that is what time in range is requirement by international body. And if those who are on hybrid closed loop system, advanced hybrid closed loop system, 780Z, their achievement of time in range will be more than 75% of the time. We had recently published our Indian data, which is almost comparable to international any country. You can see those patients who are put on a hybrid closed loop system, more than 75% of the time their sugar is also achieving a tighter glycemic control too. Let me give an example of one more patient of mine, a 11-year-old boy with a 8.5 years of a diabetes, type 1 diabetes, put on a multiple daily insulin injection. Sugar was never controlled. Then we put him on an older insulin pump therapy, sensor augmented pump therapy, but still the pump was not very good control. These type of continuous glucose monitoring report used to come. And then we had put the patient on an AI, that is 7ETZ. And you can see not only the basal, which is different times of the day, requirement is different, but multiple times bolus injection has been given. That's a correction bolus which has been given, and patient A1C, you can see, had come down to less than 7, with 75% of the time, 76% of the time, the person's sugar is remaining under control, that is between 70 to 180. To summarize my talk, HbA1c is the gold standard for diabetes management, and however, it does not demonstrate a holistic or a very individualized glucose profile. Glycemic variability is associated with increased risk of severe hypoglycemia, diabetes complication, and reduced quality of life. Time in range provides a closer view of the person's glycemic status, and it aids in a better glycemic control. To improve time in range for type 1 diabetic person, use sensor augmented pump, and now it is advanced hybrid closed loop pump therapy which is available. International guidelines have now been updated to include consensus on continuous glucose monitoring, data interpretation, and use of pump for type 1 diabetes. And there is a need to exist move beyond HbA1c alone and also consider CGM data and insulin pump therapy for optimal diabetes management. With this, I once again, thank you everyone for joining this and giving me, and thank you IJCP for giving me this wonderful opportunity. Thank you very much. Hello. Any question? Hello.